Hello, everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm honored to welcome you to this week's webinar titled Symptom Management in Head and Neck Cancer. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. And our programs include support groups and healthy lifestyle classes, social activities, and educational programs such as this one. And if you would like to learn more about our services or watch our past webinars, please visit our website at cancersupportla.org. And before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter questions into the Q&A feature found at the bottom of the Zoom window at any time, and we really welcome those questions. The questions will be answered at the end of the presentation, and we may not be able to get to all your questions today, but we will get to as many as possible. And now I'd like to introduce our speaker. Akanksha Sharma is a board certified in neurology, neuro-oncology, and palliative medicine. She is experienced in the treatment of primary and metastatic brain tumors, neurological complications of cancer, and disease-related burden and symptoms. She practices neuro-oncology and runs a supportive care clinic at the Pacific Neuroscience Institute at St. John's and is Director of Neuro-Oncology Clinical at St. John's Cancer Institute. She brings a unique perspective to neuro-oncology care with her clinical experience combining neuro-oncology and palliative care. Her research focuses on understanding and improving quality of life, how we best manage symptoms, the importance of prognostication, and caregiver support. And she partners with her patients and their families to develop holistic care plans that take into consideration both mind and body health and the patient's loved ones. And it gives me the greatest pleasure to welcome today's speaker, Dr. Akanksha Sharma.
Thank you so much, Kathy. Thank you for that kind introduction. It's an honor always to be here with CSCLA. Our whole team loves partnering with CSCLA, and we thank you for the important service you provide to our patients, no matter what their diagnosis. So I'm really thankful for all of you, and I do love working with all of you. So today we're going to talk about symptom management in head and neck cancers. From my lens, and here I'll really be speaking more as a palliative care physician and taking off my other hat of neuro-oncology or brain tumor care. So our goal today is to explore the patient journey through head and neck cancer treatment, emphasizing the impact of various modalities and on symptoms and the overall patient experience. We'll talk about how each of these treatment options, which have come a long way, do impact the patient experience and how they do that in different ways. And we'll examine the prevalent symptoms associated with head and neck cancer and delve into effective management strategies for the same. We're also going to demonstrate how there's multidisciplinary care that needs to happen so that patients can get the best care possible. Just a minute while I make sure that my notifications are muted so we are not interrupted. And of course, this is the moment that someone decides to clean something outside my window. Apologize for that. Okay, so we're going to start with a case example. This is a patient of mine. It's a true story, but we've changed a lot of details to protect them. But so this is not true, his full story, but essentially a 55-year-old who has a lesion identified at the back of his throat. It has a really great hygienist who finds something, and they go and get a biopsy and shows that it's a HPV positive squamous cell tonsillar cancer, which is the more common cause of squamous cell cancer of the throat. When he gets a PET scan, it thankfully shows that it's only in the tonsil. But when they do the biopsy, it also seems that it's aggressive and it's high grade, so it's more likely to spread or come back. So as a result, he goes to see a surgical oncologist and he gets set up for surgery in the coming weeks. When we as oncologists see a patient who has a new diagnosis of cancer, we use something called the National Cancer Center Network guidelines to kind of decide, okay, what is important, what are the next steps in the care, what should we do next? And these are agreed upon guidelines based on a lot of research and evidence. And for head and neck cancer, the first page really highlights the importance of multidisciplinary care. So head and neck surgery, radiation oncology, medical oncology, plastic surgery, dentistry, PM&R. And the reason all these services are involved is because we are going to experience a whole range of symptoms throughout the journey, and we want to make sure that we have the appropriate specialists for that. There's psychiatry, palliative care, pain management. And so it's not one person who runs the ship, even though you might start off seeing a surgical oncologist. You really want to be in a center where there are specialists from all of these different fields that are involved in your care. And the supportive care services that are necessary include everything from pain management to dental care to coordinating care. It's all these specialists, which is often done by palliative care, to physical therapy, speech and swallowing therapy. And sometimes when people need devices like tracheostomy, they need care for that. So we'll talk a little bit about all of these different areas as we go through, but at the start of the diagnosis, the patient is introduced to one person and then eventually is going to see all these different people. And so it can be both good from a support perspective, but very overwhelming from the idea that you're introduced to this whole new world of care. And you need all these different specialists for different things. So we also want somebody who is the one person leading the ship, and often that might be the palliative care doctor or the medical oncologist. So then within that same network of guidelines, if you look at what the next steps are recommended for this kind of cancer, they say, okay, first you should get surgery, and then you should get or you can get radiation, or you can do a clinical trial. And then after you get surgery, if there's anything that's concerning, like positive lymph nodes, or you have a margin that's positive, then you might get radiation also. So it really is a guideline, and this is not set in stone, and every oncologist will base the decision based on how the patient is doing, what their other problems are, how widespread the disease is, and their age, all these kinds of factors. But most commonly, treatment for head and neck cancer involves surgery, either a localized surgery to take out an area that's just a small amount of cancer, or you can have a radical surgery where you're really taking out a significant amount of surgery of tissue. You're getting more negative margins. You might even be getting extra negative margins because you really want to be sure that this high-grade disease doesn't come back. And if you do that radical surgery, you might also need to do a graft or reconstruction, because obviously these are sensitive areas of the head and neck. And we want to make sure that we do the reconstruction in a manner that's good for the patient, that's aesthetically good, and that provides them with function. After surgery, they might do radiation, and this is usually a fractionated radiation, and sometimes you might do a boost to the location. But fractionated radiation means that it's spread out over the course of several weeks. And so patients are getting radiation every day for 4 to 6 weeks. And the dose of radiation differs on the tumor. And then sometimes you might get a boost to some areas. And then you generally do chemotherapy with radiation, and after radiation, a little bit of chemotherapy. And in more recent years, that might be switched to immunotherapy or a combination of immunotherapy and chemotherapy. There's a whole host of options when it comes to chemotherapy, because it depends very much on the type of cancer, on the location of the cancer. So this is just, and I'm not going to go through all of these, but just to show you that there are many different regimens. The most common regimens are cisplatin and docetaxel. And then there are also etoposide-based regimens, or cetuximab is the immunotherapy that I was mentioning that might be useful in certain circumstances. So there might be a broad range of options, and I won't go into chemotherapy-related side effects today because that really could be so many different options, but we'll focus on some general non-specific side effects from treatment. So each of these has a different impact on the patient. So the cancer itself might be causing pain, a foreign body sensation, which can be incredibly uncomfortable. It's called a glomus sensation, where you feel like there's something in your throat, because there is, and it's difficult to get that feeling away or stop thinking about it. You can have bleeding, ulcers, and then surgery will cause, of course, pain again, healing issues, skin grafts, skin and jaw tightness, appearance changes. We have to think about radiation in terms of immediate side effects, which can be dry mouth, pain, mucositis, change in the voice, difficulty swallowing. And then long-term radiation has impact on the tissue and the nerves, muscle, bone, everything that was in the way of radiation will eventually have some kind of impact, and that's called necrosis, or it might be long-term radiation-related inflammation. And then, as I mentioned, the IV therapy use or chemotherapy use is going to have a whole range of symptoms. The emotional impact of the new diagnosis and also throughout the journey is very significant, right? Patients are experiencing shock at the initial phase. They might be very fearful of what is to come because it's such a big commitment in terms of surgery and treatment. There's anger. Why did this happen to me? Why now? What will I do? There's guilt and blame often. And patients are not surprisingly overwhelmed by information, and that can result in challenges with coping and processing, while at the same time you're making all these appointments, you're talking to people, you're meeting new people. So all of that together is incredibly overwhelming, as you can imagine. There's a lot of uncertainty in this phase and throughout the journey. Will this cancer come back? Will I be considered to be in remission? Will I need to have more treatment? And of course, facing cancer, no matter how small or large, there's the fear of dying and the fear of living in a difficult situation, which is called existential distress. And then we'll go through all of these physical impact, but this is just on this slide. I wanted to give you an impression of all the symptoms, so that just for you to see like the overwhelming nature of all these symptoms, which some of you may have experienced yourself, but just to acknowledge and validate that there is so much that is happening when you're going through treatment for head and neck cancer. And all of those symptoms and the emotional burden results in changes, it results in a psychosocial impact. So it affects the way that people interact with their family, their loved ones, their community, their ability to work, their ability to do the things that they're used to doing. It might make people shy to come out of their house because their appearance is different, because they have to have reconstruction. There might be periods where it's not safe for them to leave the house because they're getting a chemotherapy and their counts are low, or radiation is causing side effects. Of course, with head and neck cancer, we're thinking about changes with the voice and with communication, and that can be temporary or it might be permanent, and that's really difficult. Our voice is such a big part of how we relate to the world, and the world is not very kind to people who are not talking clearly and effectively. And so that impacts, people's desire to go out, do things independently, even go to the store, because we know we're worried about how the world will react to us. Eating is a very social thing in our community, in all human culture. And so not being able to eat, or not being able to eat the things you want, or needing a special diet, and even a feeding tube impacts our life and our community, our ability to go out to dinner. There is, or as I already highlighted, a number of specialists involved in care, a number of appointments, and you're going from radiation to physical therapy to senior medical oncologist to senior radiation oncologist, and it's quite a bit. Patients are often not able to work for many reasons that I've highlighted. And the burden of care in this country, of course, leads to significant financial toxicity. So all of these also impacts patients going through head and neck cancer, and I consider this to be a symptom of the journey. So our patient who now has tonsil cancer gets surgery, and they have resection of the tonsil, and they also sample a few of their lymph nodes, and they find that 2 of the lymph nodes are positive. And so the patient enrolls in a trial of high-dose radiation along with chemo. The radiation is focused to the back of the throat and neck, and because it's a trial, it's looking at an even higher dose of radiation than normally used. So they complete 6 weeks of radiation chemotherapy. and they have significant weight loss, difficulty swallowing, weakness and fatigue, eventually needing a feeding tube. Their voice starts to change, and because their job is being a pastor, they're not able to really return to work. It's become quite slurred and quite hoarse. But at the end of this treatment, he is thought to have he's received full treatment, and his follow-up doesn't show any signs of disease. So that's great. From a cancer perspective, we've done everything we could. We've treated you. You're doing well. There's no cancer. However, from a quality of life and just living and just doing health perspective, there's still challenges. Over the next year, the patient continues to have worsening issues with swallowing, never really able to get the feeding tube out. The tongue starts to become really weak because they find out that from the radiation there was cranial nerve injury, which is very involved in our ability to swallow and talk. There starts to get tightness of the muscles on the left neck and jaw, difficulty turning the head and opening the mouth, which is part of the radiation-related fibrosis. As I mentioned, they have to have a feeding tube placed. And so several years later, the patient remains cancer-free from a high-grade aggressive cancer, which is a huge win. There's no question about that. But there's a lot of side effects happening in there. And when they see me in clinic, we also diagnose them with mandibular osteoradionecrosis, which I'll talk about later. And they require oral surgery. So you can see that the journey is long, the journey is hard, and you have to make a lot of sacrifices to get the story of being cancer-free. So now I've highlighted all the things that can happen, but can we do anything to help our patients? How do we manage the symptoms? How do I help patients like yourself when they come to clinic? So the most important thing that I've highlighted many times is that it's not a single person or a single specialty. Multidisciplinary care, seeing people who are from different specialties is incredibly important. It's incredibly crucial, ideally from the very first point of diagnosis, but especially during radiation after radiation ends. So I want to start off with the emotional and psychosocial issues that I mentioned. These are very complicated, really difficult feelings, and they are very valid, but of course they affect our functioning. So we want to be sure that we support our patients as they go through this. One of the first things we can do is offer a combination of counseling and mood treatment. So when I say mood treatment, I'm talking about antidepressants, anti-anxiety meds, and that'll depend on the patient and what other problems they might have, what other meds they're taking, and if it's an anxiety diagnosis or a depression diagnosis or something else. And people are often nervous to take medications because they feel that, I won't be able to come off of them, or why do I need a medication to treat my mood? But we're going through some incredibly hard human experiences. The radiation is affecting structures that are near our brain. That we know that radiation causes inflammation. Inflammation can affect our neurotransmitters. So I also think there's a lot of physiological reasons why our neurotransmitters are out of whack, apart from the fact that we're just having, a huge issue that's affecting our life. So I really encourage people to consider medication as an adjunct to counseling and therapy and to support groups. So what kind of counseling should we get? There's a lot of different kinds of counseling out there. I always recommend patients consider serious illness therapy or meaning-centered therapy. And then there's also a school of therapy called dignity-based therapy. All of these have been shown to help specifically in patients with cancer. Meaning-centered therapy focuses on meaning and why did this happen? What should I do about this? And evidence shows that patients who have action and plan for it and feel better about the meaning of why this happened are able to cope better. Dignity-based therapy helps people regain the dignity that they've lost from cancer and from the experience of healthcare. And so it's very helpful in trauma from healthcare. And then there's also cognitive-based therapy and serious illness therapy, which is just focusing on how do we cope? How do we find new mechanisms and practical ways of coping? So this is offered through many counselors in the community, and sometimes palliative doctors do it too. Support groups can be incredibly helpful. Not everyone feels a support group is right for them. They might go attend one, feel like it's not for them. A few months later, they might go back. I always ask people to try it a couple times before writing it off. And maybe after a few times, you're like, this is just not for me, and that's okay. But it's sometimes can be a really great way of knowing other people who are walking the same journey, and no one can understand your journey as well as somebody who's been there before. Regular exercise has been shown in many, many trials to be very effective with mood and fatigue. And we'll come back to the exercise again and again in the other symptoms. I just came back from the American Society of Clinical Oncology meeting, and there were many trials to show the positive impact of an exercise regimen on patients with breast cancer and lung cancer, and we can sort of extrapolate that to head and neck cancer. And this has been mostly aerobic exercise, but also strength training. Meditation and mindfulness are techniques that have a lot of evidence, along with gratitude practice, to improve quality of life, to improve feelings of well-being, to reduce depression in patients with cancer, to reduce existential distress. It's really incredible, a lot of the research that's out there that we may not be aware of that shows that mindfulness and gratitude can help change the way our brain is facing a situation, which in turn helps us feel better. We really need the help of social work and financial counselors to address some of these other issues as it comes to disability, finances, social work, grants that may be available, disability services and education. And what I mean by that is helping patients be prepared for the disability that they're going to encounter, including voice changes or feeding issues, making sure that they're provided with the right education and tools for that. Preparing for the future, whether it's all outcomes, I think can be really important in reducing stress for the patient and the family member. It has definitely been shown again and again that advanced care planning, which I define as preparing for all possible outcomes, it reduces stress and anxiety in the family member. But even in patients, there can be an initial feeling of like, okay, I don't want to talk about this. I just want to stay positive. I don't want to talk about all possible outcomes. I only want to talk about the best possible outcome. But if you keep having that conversation and intermittently, you actually feel more empowered and in control, because cancer is a very uncontrollable situation. And in that uncontrollable situation, you are making decisions for yourself, not just for now, but for the future. Like, okay, do I want a feeding tube? Yes. If I have a feeding tube, this is the period of time I'm going to be okay with it. If something unpredictable happens, this is what I want my loved one to do. So you are really having a say in your care, and that can be a positive thing rather than a negative thing. And so I really use that as a way for us all to feel empowered and emotionally less stressed and anxious for the uncertainty of the journey. And then a huge part of this is supporting the care partner and the family, because if the family is supported, then they'll be able to support the patient more, especially in these emotional aspects. And being a care partner for someone with any kind of cancer can be a very exhausting journey, but we want to make sure that they're also supported in it. So those are kind of my discussions about emotional and psychosocial domains. We really need a lot of research in this field. We really need to know what other interventions can help. We have very little research, so a lot of this is extrapolated from the general cancer literature. There's very little funding dedicated to patient symptoms in any kind of cancer, including head and neck cancer. And so there are not more slides on this because unfortunately there's just not enough research on it. We know things that theoretically are good, but there needs to be specific information on like what kind of devices are better for communication, what kind of medications are better for depression in head and neck cancer. And those trials unfortunately just don't exist. So I'm kind of providing an overview of things that I try to make sure my patients are getting access to, but we really need more data to provide an evidence-based sort of recommendation. But when we move on to physical symptoms, there are more data and more information. So you'll see a lot more information in the upcoming slides. But I want to be clear that that doesn't mean that I consider one to be more important than the other. We really want to make sure that both the physical symptoms and the emotional aspects of the journey are addressed. So we'll start with pain control because that's a really big part of the experience right away, starting from diagnosis all the way through surgery, radiation, and treatment. So pain control, the first question is, where is the pain coming from? Is the pain coming from the tumor? Is it coming from surgery or ulceration caused by the tumor? Or during radiation, the pain may be coming from mucositis, which we'll review, or dermatitis. So it's a really combination of things that we might need to address. But this is just an overview in terms of pain can come from the nerves that are involved in the area. For that, we need nerve pain medication like Cymbalta, gabapentin, Lyrica, or pregabalin and nortriptyline. And then if pain is really severe, especially during surgery, radiation, we will need opiates. And That's not a bad thing, and people are very scared of taking opiates because, especially in the current opiate epidemic, people are so worried of getting addicted. Research shows that patients who have cancer, who need pain meds, who are in pain, do not get addicted to the pain meds because they're not taking it for a high. They're taking it to control their pain, and that's all that does is controls their pain and brings them to the same level of feeling, or even not the same level because they're not 100%, but more normal level of feeling like all of us would feel. Versus if you're taking it in a situation where there's no pain, that's when it's going to take you up to a high or technically a low. So I try to encourage patients to say, we are hoping that once you're through all this, we'll wean it off, we'll work on it then, but for now, you really need this. And I've had patients who are 2 years out who have slowly weaned off of their pain meds. But for severe pain during treatment and radiation, we want to be able to use opiates in small doses, in needed doses, and often we'll time the doses, so it's prior to meals, prior to oral intake, because what I really don't want is patients to have been in so much pain they're not eating anything at all, because we need nutrition to be able to sustain this journey. There's an opiate called methadone that actually can be incredibly helpful because it works on both nerve pain medications and nerve pain receptors, and also muscle and bony pain. Patients are often scared of methadone because they associate that to heroin use, but methadone is actually independently a very good pain medication. It has to be given by a specialized pain or palliative care specialist because it has specific ways of titration. However, it is used often to help patients who are weaning off other opiates, and that's why it has that kind of reputation. But I encourage people to consider and ask their doctors about that. And then after radiation, if their pain is coming from muscle tightness, then other techniques that might be helpful would be trigger point injections, where you really have a very tight muscle from radiation-related fibrosis, and you can go in there and inject some lidocaine or steroids and loosen it, and that can be very helpful for pain, Botox or acupuncture. So the second most common thing we see is weight loss, because you're getting surgery, you're getting radiation all to the area of where you swallow. There's pain in the mouth, and so patients don't feel like eating, understandably. And so going back, it kind of connects to the first thing. If we have good pain control, we might be able to take better oral intake, stay hydrated, and keep our meals in as much as we can. And we want to focus our intake to high calorie, healthy food. So patients often ask me, like, what diet is best? And there's no one diet that's going to make your cancer go away completely, but there are definitely diets that'll help you have a better experience, help you feel better, and will help you reduce the inflammation in your body, which all helps, but also keep your nutrition up, like keep your weight up, keep your protein levels up, so that the healing will happen better. And so what diet is that? It's really the closest thing is the Mediterranean diet. So you have a diet that's rich in whole foods and nuts, in oils, lean meats, fishes, avocado, all these kinds of things. And the more you can incorporate those things, the more we worry less about, okay, how are things healing? How's your protein level and things like that. Meeting a dietitian can really help. And then, as we discussed, as we're going through the journey and your body is changing, and the counseling and therapy can be really helpful in accepting the changes that are happening and making sure that that's not contributing to poor appetite. It is not uncommon that during head and neck cancer treatment, patients will need feeding tube. And so that's something the oncologist and the radiation oncologist and surgeon might decide together. They might place it prophylactically, meaning even before any weight loss starts to occur, because they know it'll happen. And so a part of this might involve teaching and training around feeding tubes, and also getting over the mental stigma of needing a feeding tube. Often in cancer, you can have a condition called cachexia, meaning the cancer is causing all this inflammatory changes that's causing muscle and weight loss. And that's a little bit different. That's not just poor intake, but it's this process that's happening. And for that, there are a few medications that are out there. And there are also some trials that are ongoing to see how can we help patients with cachexia, but that's usually a sign of late cancer. So of course, voice changes. Patients will have voice changes if the cancer is near their voice box, or even if it's around the neck area and they have surgery that impacts it, or they during surgery, the nerve gets affected, or during radiation, the nerve that helps our voice box might get affected. Often patients may need incision in the throat and a tracheostomy, and so then they won't be able to speak until they have a device. So these voice changes are obviously very impactful on our mind, on our well-being, and so counseling and therapy is a big part of it. There's also assistive devices in a more practical aspect. So this, for example, is a device that we put on at the trachea that helps us control air coming up, and so you can speak. And then this is called an electrolarynx, where it's basically a device that's helping the voice box amplify the voice coming from the voice box directly. There are now, with smart devices, new applications that are being made that are used by patients who have head and neck cancer, and also conditions like ALS, where it's easier for them to communicate. This is just an example of one of them, called Proloquo 2Go, which helps patients express themselves better. Then we also want to make sure that their mouth, the dryness in their mouth is well treated, saliva is well controlled, so that that's not impacting this voice. So optimizing everything else that we can. So one of the things that impacts weight loss is the way things taste. Because of radiation and maybe chemo at the same time, things will taste different. Patients often report a metallic taste or just tasteless. Sometimes sense of smell is affected, so if you can't smell it, you can't eat it. And then very rarely I've had patients with some chemo type say that everything tastes like garbage, which is awful. And so of course, if you can't taste well, you don't want to eat. And so what do we do in that case? That's a hard thing to manage, but we try as much as we can to encourage different techniques. So using a dietitian, again, in that aspect is very helpful. Over the years, I've found that zinc sulfate is an oral supplement that can help change the pH of the mouth and change the perception of taste. Lemon candy can be helpful. Baking soda rinses, especially if it's an issue with saliva and pH in the mouth. The fast technique is something that can be helpful. It's mostly to improve how food tastes, but in patients who have very damaged taste buds, it can help make food taste at least a little bit better. So that means going towards spicy foods or sour or salty foods. So if something is too bland, you can add a little bit of lemon. And so we encourage ways that you can improve meals at home so that you might be more willing to eat them. And then if all of this doesn't work that much, the main thing is like getting calories in. So can we do shakes? Can we do high calorie things that you can just chug, even if you can't? Of course, the enjoyment is a huge aspect of it, but during radiation, at least keeping your weight up as much as you can. Fatigue is the #1 symptom experienced by most cancer patients. It's one of the most common symptoms around the world for cancer patients and is independent of cancer type. And we've done a lot of different studies for fatigue, and it's been very hard because fatigue is, of course, a subjective thing. It's very multifactorial, meaning so many things can contribute to fatigue, including your mood, your sleep, the cancer itself, the treatment you got. So many different things. But there are some things over the years that have shown good evidence. So aerobic exercise, I already mentioned, is one of the big ones. 20 minutes of exercise every day, or 3 hours a week of good aerobic exercise, whatever you can tolerate, even if those 20 minutes are broken up into 4 different parts of a day. Something to get your heart moving and the blood flowing. Yoga has been seen to help with fatigue. Acupuncture, there's a lot of studies out of China and other countries where acupuncture is more prevalent that shows that it does have evidence in fighting fatigue, especially with a good acupuncturist. I try to make sure that everything else is optimized and not contributing to fatigue. So that means thyroid labs. So patients get radiation to the neck that can affect the thyroid, not just immediately, but long-term. So we keep an eye on it. Vitamin B and B12 and vitamin D levels can affect fatigue. There was a study done on American ginseng many years ago that showed that patients who took a gram of American ginseng a day had improvement in fatigue if they were radiation patients. This trial is a little controversial nowadays, but there does seem to be some benefits for some patients with American ginseng, and so it's something that's relatively safe to try. I often have patients add a vitamin B complex and multivitamin to their regimen if they don't mind the pills, and then making sure that they're sleeping well. And so to that end, melatonin and magnesium are really helpful tools in sleeping, because understandably, as you're going through all this journey, sleep will be impacted. So dermatitis is something that can happen during radiation, where there is inflammation of the skin, right? Because we're radiating through. And most times we don't really see these severe burns like we're seeing on the bottom here. That's incredibly rare. And that might be very sensitive skin, because most of the time as the radiation inflammation is getting worse, the radiation oncologist will stop the treatment or lower the dose or make some changes so that the burn doesn't get worse. How we manage the dermatitis is by emollients and other skincare. Aquaphor is a popular one amidst radiation oncologists. Vaseline or barrier ointments is another one. Sometimes we have to use steroids if it's really inflamed or open. This is an important thing that I learned from a dermatologist, is that we don't actually want to put neosporin on anything there, because neosporin has agents that people can be allergic to or react to, and they may not even know. And so that can sometimes make the burns worse or make the areas worse. So anything with too many ingredients, like keep it really simple. Keep it simple to Vaseline or something that has 1 or 2 ingredients. If the burn does occur, you would monitor it closely like you would with any other burn, not itch it, not try to peel the skin, avoid any infection of it. And sometimes if it is dry and itchy, then anti-itch creams may be needed. And then if you're already getting a burn from radiation, you have to be very careful in the sun. And so during radiation, I don't suggest people go to the beach, because sunscreen doesn't last that long and they forget to reapply. So just trying to be safe, making sure that you're wearing a big hat under an umbrella, reapplying sunscreen throughout the day. If patients are past radiation, and they can start to develop muscle tightness and scar tissue, and varies how quickly after radiation this might happen. Some people it's a few months, some people it's years. And this is called radiation fibrosis. Again, an area where we really need to do more research and find more options for patients. Right now, we're kind of putting together a lot of different treatments that we know work. Vitamin E and Trental is a combination that can help some patients with inflammation and lowers the inflammation. Massage to sort of loosen the muscle tightness, although the problem with massage and acupuncture is that it is short term, it's very brief, and then everything gets tight again. Stress can be a trigger to make the muscles even tighter. And so, for example, with TMJ or temporomandibular joint syndrome, where you have headaches from stress of the up here on the temporal lobes, the same thing will play here. So if you get stressed, you might immediately experience that your jaw gets tight, because the muscles are responding to your tightness, to your stress. Trigger point injections, which I talked about before, can help. They don't help very long, but more than a few days. They usually can help for a few weeks. I have a patient who's many years out and has a little bit of tightness in the neck, and we treat him every 2 to 3 months, and he really gets a lot of benefit from it. Botox might last a little bit longer, but needs a more specialized person to do it. And then very rarely you might need the scar tissue to be removed. Hyperbaric oxygen is a technique that's helped with radiation-related inflammation and wound issues, where you basically have to go through a hyperbaric oxygen machine, and the oxygen can help reduce the inflammation in that area. And then it's very important to get good physical therapy and lymphedema therapy, so you're massaging the fluid that develops in that area. Mucositis will happen in patients during radiation. Usually gets better at the end of radiation, sometimes happens with some chemotherapies. But with radiation, you really, as much as you try to avoid any amount of radiation to the mouth, you're going to get some out dose. For everyone, it seems to be very different. It's kind of based on how some people get a lot of ulcers and get very sensitive mouths, and some people never have had an ulcer in their life. So we really don't understand the risk factors, but definitely a variety of things can cause it, including vitamin deficiencies on top of the radiation. It might be a mildness, like a mild redness, or you might start to get grade 2, where there's some white patches and you're still able to eat and drink, but it's a little bit more uncomfortable. If it goes to a grade 3 where there are ulcers that are bleeding, then we might need to do IV nutrition or tube feeding, as I mentioned. And then grade 4 almost never happens, which is great, because that's life-threatening level of ulcers. How do you manage the mucositis? So definitely, as I mentioned, pain control is huge, especially before oral intake. So often I'll say, okay, take this pain medicine 30 to 45 minutes before you eat food, before you try to eat food, so that you can reduce the pain in your mouth. It takes oral pain medications about 45 minutes to work. They're not that fast compared to IV, so you have to give yourself enough time. Or I might say do a mouthwash before you eat, trying to make sure that they can keep up their nutrition. And then, of course, you can still use meds outside of that, but those are important time points. Mouthwashes can be really helpful. Mouthwashes with steroids, mouthwashes with ketamine can be helpful for pain. And these have to be compounded together, and so compounding pharmacies have to make them, and unfortunately, insurance doesn't cover them. But they range between $50 to $100 sometimes for a bottle, and they can be incredibly helpful in reducing the ulcers in the mouth. And I will mix them with, as I mentioned, steroid, Benadryl, maybe hydrocortisone. You don't even have to swallow them; you just swish them around for a while and spit them out. I supplement patients with oral B complex and folic acid, and that seems to sometimes help in preventing ulcers. We talked a little bit about monitoring for labs, for energy, for thyroid hormones. And then as people go farther and farther away from their treatment journey, we want to make sure that we're providing survivorship care. So we're doing lipid management, A1C management, and everything else that we would do in patients who don't have cancer. Dental and bone health is something that seems to be people are less aware of, but radiation has an impact on your dental health. It's causing inflammation in those teeth, and it's causing increased plaque buildup. So after radiation, really need to have regular cleanings. I would even say every 3 months instead of every 6 months, which most people are doing. And then you may need to assess the bones in the field of radiation and follow-up imaging. This is something people aren't aware of until something happens, like they start losing teeth or they have pain in their jaw, and then they find that they have something called osteoradionecrosis. And osteoradionecrosis basically is a long-term complication of radiation, which is not common, but it does happen and can be painful, where the bone is starting to die away. This is an example of osteoradionecrosis where you're missing the bone there. That means the teeth don't have anywhere to latch themselves to, and that can be not great. So we want to do calcium and vitamin D supplementation for bone health and dental health after radiation, just for everyone, all comers, because it's not harmful for you. But we also want to monitor. And around that same aspect, another thing that people are not aware of is that everything that's been in the field of radiation is going to get impacted. And the longer someone's living, we're now learning more about the long-term side effects of radiation. We used to know that in the first 6 months, you can have side effects that may improve or may get better with time or may not get better with time. But now we also know that even years out, sometimes some things change in the nerves that can cause symptoms. So this is an example of the side of the face. So if you got radiation that affected this whole area, these are all the nerves that would be in that field. So you might have the nerve that goes to the jaw muscles here. You might have the nerve that provides sensation to this part of the face. You also have the vagus nerve that runs through here, which is very important for different functions in our body, including blood pressure management. So there's a lot of important structures that run through here, including your brainstem. And so we really have to be mindful. And that's why it's of course important to get a good radiation oncologist and a good planning for radiation. But it's not uncommon. Well, it is rare, but I do see the worst of the worst. So I see this is 1 to 5%, like incredibly rare side effects. But patients can have nerve weakness that leads to the muscle weakness. So the tongue starting to get weak, several years later, or having some numbness of the face several years later. It might be that the nerve is just shocked, which is happening during radiation, and it's going to recover and heal, or it might be that the nerve dies over time, which is irreversible, and new nerves don't form, although the same nerve can regenerate sometimes, what we're learning. I have used hyperbaric oxygen in some of these patients. There's really no trials or any data, but we have tried that with some benefit. Magnesium is a very good supplement for nerve health. Again, low side effects, so sometimes I encourage people to just be on it. We talked about vitamin E and Trental. If the nerve dysfunction is causing pain, we'll use nerve pain medications. Anti-inflammatories or steroids can be helpful. And then in the same way, the blood vessels that are sitting around here can be impacted over time, something called vasculopathy, meaning vessel damage. And one of the long-term side effects that we want to monitor from radiation treatment of head and neck cancer is secondary strokes, because if the nerve the vessel gets inflamed, it can cause stroke. So we want to keep an eye on it. That doesn't mean that it's common again. It doesn't mean, I don't mean to scare anyone. It's very rare, less than 5% again. But we want to monitor them. We want to make sure that if something is happening, we prevent any further issues by using things like aspirin or blood thinners or cholesterol modification. So I want to give time for questions. So that's why I could talk about a lot of different things, but I want to stop here and just remind everyone that diagnosis of head and neck cancer triggers a cascade of symptoms, and this treatment has to be multidisciplinary. You don't want to go in a place where there's just one person who's running the ship and they don't have access to all these other specialists that you absolutely need. Appropriate early and thorough symptom management is really important. The earlier we can help get the symptoms under control, the easier the journey will be, and patients will be more successful in getting through the treatment. And at this point, I would make a plug for palliative care, because people get scared of palliative care, but palliative care is can be incredibly helpful in helping patients with head and neck cancer get through the journey. If you're getting through the journey, you're going to get through treatment, and you will not need things like hospice, which is palliative care at the end of life. But palliative care at any point before that is not hospice. It's not the same as hospice. And hopefully I've shown you that we have expertise that can really help patients with head and neck cancer. Our patients are living longer, which is really exciting. It's really amazing, but that means that we also need to manage the long-term side effects, so that we don't want anyone to have to compromise on quality of life in exchange for living longer. There's a great documentary with Suleika Jaoud and I don't remember his name, but the musician who just won a lot of, John Baptiste. Her doctor says to her at one point, which really stayed with me, is the goal is to live. And I would say live well, not just survive. So if we're going through treatment, we're trying to make sure that you live well, and we need to do everything that we can to make that happen. So thank you so much for having me, and I'll take questions. I'll stop sharing and see.
I jumped on. I want to invite everybody to put their questions into the Q&A feature found at the bottom of the Zoom window. We'll keep our eye on those, but Dr. Sharma, we did receive a few questions at registration, so I'll throw a couple of those your way. Someone is wanting to know, what are the indicators or symptoms that folks should look out for to know if they have a head or neck cancer? It's kind of a broad question, but what are symptoms that are concerning?
Yeah, that's a good question. So often a lot of patients will be identified by dental hygienists or dentists who are doing a good mouth exam. And so that's why it's important to go to your dentist every 3 to 6 months and make sure that someone is doing a good exam, looking at the back of the throat, because if the lesion is small, you may not notice it or feel it. The second way is that people can start to have pain in a particular area, or an ulcer that won't heal. It's been months and months and the ulcer won't heal. If they have a history of smoking, or they have known HPV exposure, then they're at higher risk. And so that's even more important, that you note something that feels different in your mouth and bring it to the attention of somebody. The trickier ones are esophagus or lower neck, like high esophagus, and those are usually like, oh, I've swallowed and it hurts, or things aren't swallowing, or I can't swallow pills as much, or starting to lose weight because they may not realize that they're not intaking as much. And that will lead to an investigation, including endoscopy, where they find like a squamous cell cancer of the esophagus or things like that. So it's really a varied, aspect. I had one patient who had a sinus cancer, where there just was a feeling of fullness, and everyone thought it was an infection at first, and then we realized it was a cancer. And often it can be sort of abnormal drainage from the nose, because that's coming from the cancer.
And another question that's a little broad, but I think an important one. How long do some symptoms persist after surgery?
So after surgery specifically, it depends very much on the location of surgery, how extensive the surgery was. So, and a good surgeon, if you meet a good head and neck surgeon, should review with you, this is where we are. If I do this much surgery, I could get 80, 90, 100% of the tumor, but that means that you won't be able to ever swallow again in yourself, and we'll have to do a feeding tube. So those are very important decision-making points. And The surgeons I love the most are the ones who are really sitting down and painting a picture of what life will look like. So some symptoms are quick to reverse, meaning soon after surgery, you'll feel better, the wound will heal, and you'll get better from that symptom, like pain in the local area. But some symptoms are chronic or long-term or life-changing, like voice changes or swallowing issues. And it's very important to have that conversation and know, is this gonna be me? Like, am I not ever gonna get my voice back? Am I never gonna get my swallowing back? Before you take that step into surgery. And then otherwise, it really depends on how the graft is done, the plastic surgeon. So if there's a facial, for example, cancer, and they have a good surgery, they might reconstruct it, but it might never look the same. And so there's definitely a risk of irreversible symptoms.
Here's a question that came into the Q&A, so I'll let you field that one.
Is it best to see a palliative doctor who specializes in dealing with head and neck cancer rather than a general palliative care doctor? It's a great question. In an ideal world, we'd have lots of palliative care doctors who are specialized in different cancers, but actually it's very hard to find that. Palliative care doctors in general are in short supply, and I actually do brain tumor and palliative care, and there's only like 3 of me in the country. So most palliative care doctors are experienced with head and neck cancer, especially if their team is consulted often. So it's a cycle. So the head and neck doctor asks for a palliative care counsel, then they become more experienced in dealing with it. But increasingly, more and more centers that treat head and neck cancers are realizing the value of having a palliative care doctor on the team. So they're recruiting people who are familiar and comfortable with managing head and neck cancer. But what I would say is that you start off with whatever palliative care doctor you can get and see, because there might be very general things. Like a lot of the symptoms I mentioned are not specific to head and neck cancer. Like I learned a lot of these in palliative care fellowship, just in general for mucositis or for pain or tightness. So you don't necessarily need a head and neck cancer palliative care doctor. And the other question is, what is the FAST technique? So that's FAST is fruit, acid, salty, sweet. So that means that if you have a meal that you really can't taste, you could consider increasing the sweetness, you could increase the saltiness, you could add some lemon to it, so fruit to it, or acid to it. And basically using these techniques to improve the taste of the meal so that you're more likely to eat them. So if you look up FAST technique for diet, you'll see a lot of suggestions and ideas. You might also add oil to it or something for stronger flavors, because during radiation our tastes are numbed, and so we just can't enjoy meals as much.
So an additional question for you. What new treatments are on the horizon, if any, that might eliminate some of these caustic treatments?
Yeah, that's a very important and good question. For head and neck cancer, like with brain tumors, we have not made enough gains to know when can we push out radiation and how much can we put out radiation. Not that all of these things are just caused by radiation, but a lot of them are. And a lot of other cancers, we've been able to reduce toxicity by pushing out by pushing out radiation. So for example, for melanoma, if someone had tumors, we would immediately have to radiate in other parts of the body. Now we have immunotherapy that can help reduce that tumor without radiation. And so then we push out radiation further and further, and that helps. I think that's one of the areas that the field is going in general for cancer. And for head and neck, unfortunately, we haven't had the same response in some of these cancers. There are certain, for example, squamous cell cancers that respond really well to immunotherapy. There's a new immunotherapy called cetuximab, which helps with those. And so it really depends on the cancer. But there are now innovations in terms of cancer treatment with immunotherapy, T cells, smart kind of inflammatory cells of the body that will help us move away from radiation, and help us move away from the older chemotherapies that are a little bit more toxic. And I think in that sense, it'll reduce the toxicity. We also, the one area where we've already made a lot of gains is reconstruction. Like, it's incredible how much reconstruction we've made. There used to be that if patients had head and neck, for example, a nasal cancer, they just remove the neck and make a prosthesis, which obviously didn't look good. And we would say, that's how you have to live your life now. But now I have patients who get major surgery and they get beautiful reconstruction with amazing plastics and reconstructive doctors and we really value the importance of aesthetic to the patient journey. And so then patients can feel better re-entering the world. So we've come a long way there, and I think we'll continue to go a long way with surgical techniques.
Then, as a final question, what's most exciting to you about sort of the future of this field?
Um, I mean, all of it is very exciting, like in terms of new treatments. I think I take everything with a grain of salt because I also want the symptom management to come at the same time, and it hasn't been. So while I'm really excited, I think that I have some long-term survivors that I think wouldn't have been around 15, 20 years ago. So I have people who are 8 years out, 9 years out, and I want to really celebrate with them this that they've made it through high grade cancer, but they're dealing with so many toxicities that it's hard for them to get there emotionally. So I am very excited about the fact that I even have these survivors and I can learn from them and work with them. But at the same time, I take that with a grain of salt that I hope we have better solutions for their side effects.
Wonderful. Well, we have reached the end of our time together. I think Abby is going to share a resource slide from CSELA. Dr. Sharma, thank you so much. That was such a meaningful presentation, so broad in its scope, and the focus on symptom management in particular was incredibly meaningful. So we thank you for your generosity of time today. If you would like to learn more about Cancer Support Community Los Angeles, you can visit our website at cancersupportla.org. And if you have any questions, you can email info@cancersupportla.org. Also, Dr. Sharma has generously agreed to share her slides today. So if you would like a copy of those slides, please email us at info@cancersupportla.org. As a final point, we have a flyer up for our brain tumor support group. But if you are interested in a head and neck cancer support group, please email us also at info@cancersupportla.org. We are interested in starting a group, and we need to know how many interested individuals there are. And we thank you for your time and participation today and hope to see you at the next educational webinar. Thank you, everyone. Have a great weekend.